Welcome to the deep dive. Today, we're getting into something really, really important, especially if you're prepping for exams like the MSRA. We're talking about papilloedema.
hmm
You can sort of think of it as your body putting up a big red flag saying, hey, pressure's building up inside the skull. We want to break down what it is, why it happens, and, what it actually means for you, whether you're studying or already practicing.
Exactly. We're working from some focused revision notes today, and the goal is really to pull out that high-yield stuff, the essentials you need to grasp, and, crucially, remember this condition.
Yeah.
We'll cover the definition, the causes, the risks, how you spot it, investigations, management, the whole lot. And we'll try to sprinkle in some memory aids along the way.
Perfect. Okay, let's dive straight in then. The definition. What is papilloedema in, simple terms?
Well, fundamentally, papilloedema is swelling the optic disc specifically. That's the bit at the back of the eye where the optic nerve plugs in, basically.
Okay.
But the key thing, what makes it papilloedema, is that the swelling is caused only by increased pressure inside the skull, intracranial pressure, or ICP.
Right, the raised ICP.
And another key characteristic, it's usually bilateral, affects both eyes.
Bilateral swelling due to raised ICP.
Got it.
Yeah.
So how does that pressure inside the head actually cause swelling we can see in the eye? What's the mechanism?
Yeah, this is where it gets quite interesting. The optic nerve isn't just sitting there, it's wrapped in a sheath. And this sheath, it's directly connected to the subarachnoid space.
The space with the cerebrospinal fluid.
Exactly. So when the pressure in that fluid space goes up, it gets transmitted directly along that optic nerve sheath right to the back of the eye to the optic disc.
Okay.
And this pressure physically squeezes the optic nerve fibers there. It disrupts something called axoplasmic flow. That's like the transport system within the nerve fibers. Things can't move properly.
Like a traffic jam.
Precisely. It causes a backup of fluid of cellular components. And that's the swelling you see when you look at the optic disc. Right.
A direct mechanical effect. But you mentioned, or the notes mentioned, that not everyone with high ICP gets papilloedema. Why not?
That's a really good point, actually. It's a subtlety. So while raised ICP is the cause, people's anatomy varies.
Yeah.
The optic nerve, the sheath, how resilient they are, it's not the same for everyone. And also how fast the pressure rises, for how long, that can also play a role. It's not an instant on-off switch for everyone.
Okay, that makes sense. It's variable. Now, for the MSRA, knowing the why, the etiology is critical. What are the big hitters? The common causes of this raised ICP leading to papilloedema?
Yeah, we can group them. The common ones you absolutely need to know are things like intracranial tumors, obviously, they take up space.
Right.
Hydrocephalus, which is that buildup of CSF fluid. Idiopathic intracranial hypertension, IIH. That's the one where pressure is high, but we don't know why, often in younger women.
We'll come back to that one, I'm sure. Definitely. Then there's cerebrovenous sinus thrombosis, a clot in the brain's veins, and malignant hypertension, really severe high blood pressure. Those are the main ones.
Okay, a solid list. Any less common causes worth tucking away in the back of our minds?
Well, less frequent, but worth knowing, are associations with hypercapnia, too much CO2 in the blood.
Okay.
And some rare links to things like hypoparathyroidism, low calcium levels, even vitamin A toxicity, believe it or not, shows how systemic problems can pop up in the eye.
Definitely broadens the picture. Now, the notes also flag up other causes of optic nerve swelling that aren't papilloedema. That seems like a key distinction for exams. How do we separate them?
Crucial distinction, yeah. Because you can see a swollen disc, but it might not be from raised ICP.
Yeah.
So other possibilities include things like non-arteritic anterior ischemic optic neuropathy, NAION for short,
Right.
optic neuritis, which is inflammation of the nerve. And confusingly, sometimes other intracranial problems can cause swelling directly, not just via pressure. So a swollen disc doesn't automatically mean papilloedema.
Got it. So the cause is the differentiator. How about thinking practically unilateral versus bilateral swelling? Is that a helpful way to approach it?
Absolutely. Big discriminator. If you see swelling in just one eye, you should be thinking more along the lines of optic neuritis and AION, maybe retinal vein occlusion, or diabetic papillopathy.
Okay.
But if it's bilateral swelling, that really bumps papilloedema way up the list, along with maybe toxic optic neuropathy or that malignant hypertension again.
Is there a memory aid for that?
Yeah, for bilateral swelling, you could think 2 T's and an M, toxic, tumors causing raised ICP, and malignant hypertension. Might help you quickly filter options in an exam scenario.
2 T's and an M. Okay, useful. Let's dig a bit deeper into those intracranial conditions causing the raised ICP. Can we flesh out that list beyond the big ones?
Sure. So besides tumors and hydrocephalus, think about cerebral trauma, a significant head injury,
Right.
hemorrhages like intracerebral or subdural bleeds, brain infections or inflammation, meningitis, encephalitis, abscesses, IIH, of course, respiratory failure leading to that CO2 retention, hypercapnia, Chiari malformations, altitude sickness, AMS or HACE, even Lyme disease has been implicated.
Wow.
And don't forget medications. Tetracyclines are a classic one, and corticosteroids can sometimes be involved too. It's a really wide differential.
Really highlights why a good history is so vital. What about those optic nerve conditions that can look like papilloedema but aren't about pressure?
Yeah, the mimics. We mentioned optic neuritis and the ischemic ones, NAION, and the archaritic form linked to GCA.
Giant cell arteritis, right?
Yeah, exactly. Then there are toxic causes. Methanol poisoning is a notorious one. Compressive optic neuropathy, maybe from thyroid eye disease squeezing the nerve.
Okay.
And sometimes people just have optic discs that look swollen, congenitally anomalous discs. And finally, infiltration, things like sarcoidosis, glioma, lymphoma, getting into the nerve head.
So lots of ways the nerve itself can be the problem. What about vascular causes of disc swelling beyond malignant hypertension?
Good point. Retinal vein occlusion can cause disc swelling, less often retinal artery occlusion, and interestingly, acute lymphocytic leukemia, ALL, can sometimes cause swelling due to lymphocyte infiltration.
Okay, so vascular and even hematological links. And that last category in the notes, other conditions, what sort of systemic things fall in there?
Yeah, this is kind of a catch-all for systemic upsets, things like glaucoma, especially if there's also a central retinal vein occlusion.
Yeah.
Weirdly, prolonged weightlessness, like an astronaut's.
Right.
Yeah, inflammatory eye conditions like uveitis or scleritis if they affect the back of the eye. Irvine gas syndrome after cataract surgery. Again, infiltration like sarcoid or leukemia. Carbon dioxide retention again. Parahypothyroidism. Uremia from kidney failure.
It's a huge list.
It is. Maybe a memory tip here is just to think systemic upset. If the whole body's out of whack for some reason, it can sometimes show up in the optic nerve.
That's a helpful way to frame it. Okay, shifting gears slightly. Risk factors. Who is actually most likely to develop papilloedema? Are there typical patient profiles?
Yeah, there are definitely risk factors to know. Obesity is a big one. Female gender, specifically for IIH.
Right.
A recent head injury. Certain medications, isotretinoin, used for acne, is one to remember. And then logically, just having any of those underlying conditions we just spent ages listing that cause raised ICP.
Makes sense. Is there a mnemonic for those?
The notes suggest one. Of hurt. Obesity, female, especially for IIH. Head injury, underlying conditions causing raised ICP. And RX for medications like isotretinoin.
OFHURT. Of hurt. Got it. Great for recall. So we know the what, the who. Let's revisit the how, the pathophysiology. Can you walk us through that sequence again? What's happening mechanically?
Okay, so step one, increased intracranial pressure. That pressure gets transmitted down the optic nerve sheath.
Yep.
Step three, it compresses the optic nerve fibers right where they exit the eye at the disc. Step three, this compression blocks or slows down that axoplasmic flow, the transport system inside the nerve fibers.
Traffic jam.
Exactly. So things back up. Fluid, proteins, organelles. Step four, this backup causes the nerve fibers to swell, and that makes the whole optic disc look elevated and swollen when you examine it.
The garden hose analogy comes to mind. Squeeze it and it bulges upstream.
That's a perfect analogy, yeah. Water backs up, hose bulges. Same idea with axoplasm and nerve fibers.
Brilliant. Now, when we see that swelling, what else could it be? What are the key differential diagnoses we need to rule out before landing on papilloedema?
Right, the mimics again. Top of the list would be optic neuritis, that inflammation. Optic disc, drusen, those little protein calcium deposits that can make the disc look swollen, but aren't true swelling.
Pseudopapilloedema sometimes.
Exactly. Drusen are a common cause of pseudopapilloedema. Then optic atrophy, although usually the disc is pale, sometimes in early stages or certain types it can look a bit swollen. And ischemic optic neuropathy, both non-arteritic, NAION, and the arteritic type with GCA.
Any mnemonics for those differentials?
The notes offer noodles. Neuritis, optic atrophy, optic disc drusen, ischemic optic neuropathy. Helps keep those main mimics in mind.
Noodles. Okay, these mnemonics are genuinely useful for quick recall. Let's talk numbers. How common is this? What's the epidemiology look like?
Well, the exact prevalence across the whole UK population is apparently a bit uncertain. according to these notes.
Okay.
But we definitely see it more in those high-risk groups we mentioned, people with obesity, and particularly women of childbearing age with IIH.
Right. The IIH link seems strong.
Very strong. And for IIH specifically, it's interesting, there's no particular racial predisposition, but it is less common in men, kids, and older adults. So that young, overweight female demographic really stands out for IIH-related papilloedema.
Definitely paints a picture. So, clinical presentation. What are the typical signs and symptoms that should make us suspect papilloedema?
Well, the absolute key sign is seeing that bilateral optic disc swelling during fundoscopy.
Yeah.
That's the clincher. But the patient might come in complaining of symptoms linked to the raised ICP itself. Headache is a big one, often described as pulsatile, worse when they wake up or when they calm or bend over.
Those typical raised ICP headache features.
Exactly. And listen out for pulsatile tinnitus, that whooshing sound in the ears in time with their pulse. That's a real red flag. They might also report transient visual obscurations, vision briefly dimming or blacking out for seconds, and potentially visual field defects, though they might not notice those initially.
How does the presentation differ, say, early on versus later, more chronic stages?
Good question. Early on, someone might actually have very few symptoms, maybe just the headache. The papilloedema might be picked up incidentally.
Okay.
But as it becomes more chronic or severe, that's when you're more likely to get persistent blurred vision, more noticeable gaps in their visual field. Interestingly, their central visual acuity reading the Snellen chart can stay surprisingly good for quite a while.
Even with swollen discs?
Yeah, initially. But in severe, long-standing cases, they can get more frequent or prolonged transient visual loss. And just to hammer it home, that classic IIH patient profile, younger woman, raised BMI, maybe on the pill, keep that in mind.
Right. So if we suspect it based on the history, what are we specifically looking for when we examine the optic disc? Any practical tips for the eye exam?
Okay, examination. First, a detailed history, nailing those raised ICP symptoms. Then looking at the disc itself. Crucially, check for an RAPD relative afferent pupillary defect before you put in dilating drops. Very important.
before.
Because the dilating drops will obviously make the pupil big, so you can't assess the relative reaction properly afterwards.
Of course. Makes sense.
Then look at the disc margins. Are they blurred all the way around or just in certain segments? Compare the color. Is one disc paler than the other? Look for spontaneous venous pulsation. The veins on the disc normally have a subtle pulse, and this is often lost in papilloedema.
Okay. Absence of SVP.
Yes. Also scan the rest of the fundus for other signs like hemorrhages or cotton wool spots. And always examine both eyes and compare.
Right. And beyond just looking at the disc, how do we test how well the optic nerve is working?
Good point. Need to assess function. Check visual acuity, the Snellen chart. Do the RAPD test, the swing flashlight test. Look for color vision problems using Ishihara plates dyschromatopsia. Assess brightness sensitivity. Does one eye see things as dimmer? And visual fields. Even basic confrontation testing can pick up an enlarged blind spot, which is common. Formal perimetry is better if available. Plus, a quick neuro exam, especially cranial nerves, is always wise.
And there's a grading scale, too.
Yeah, the Frisson scale. It grades the severity based on how swollen the disc looks, vessel obscuration, nerve fiber layer changes, goes from grade 0, normal, up to grade 5, severe swelling.
Okay, comprehensive assessment needed. So we've done the exam, we suspect papilloedema. What investigations come next?
Investigations are key. The absolute priority is urgent neuroimaging, usually an MRI scan of the brain, with contrast the gadolinium enhancement.
Why urgent?
To rule out the scary stuff. Tumors, bleeds, hydrocephalus, anything structural causing that pressure, you need to know quickly.
Right. What else?
Sometimes an MRV magnetic resonance venogram might be added to specifically look for cerebral venous sinus thrombosis, that clot in the veins.
Okay.
And then, if the imaging shows no mass lesion that could cause brain herniation.
Yeah, crucial safety check.
Absolutely. Then you'd proceed to a lumbar puncture. This measures the opening pressure of the cerebrospinal fluid directly and lets you analyze the CSF composition, essential for diagnosing IIH.
Are there other tools, maybe more advanced imaging?
Yeah, sometimes things like ocular ultrasound or, more commonly now, OCT optical coherence tomography can be really helpful. SD-OCT gives incredibly detailed scans of the optic nerve head and retina. It can help confirm swelling and differentiate true papilloedema from mimics like drusen, the pseudopapilloedema.
Okay, OCT is very useful. So we've got the diagnosis, maybe found the cause. How do we manage it? What's the treatment approach?
Right, management. The absolute #1 principle is treat the underlying cause. Whatever's raising the ICP, you have to address that.
Makes sense.
General strategies often involve weight loss. It's absolutely massive for IAH, medical management to lower the ICP, and sometimes surgical intervention.
Let's focus on IIH first, as it seems common. What's the management there?
For IIH, weight loss is genuinely first-line therapy. Even modest weight loss can significantly lower ICP. Then, medication. The main player is acetazolamide. It's a diuretic that reduces CSF production.
Okay, acetazolamide, key drug.
Absolutely. Other diuretics might be used too. And managing the headache is important. Sometimes drugs like topiramate are used, which can also help with weight loss as a side effect.
What if it's not IIH, a tumor?
Well, if it's a space-occupying lesion, then surgery to remove or debulk it is usually the primary treatment. That can resolve the papilloedema, often over 6 to 8 weeks. Sometimes biopsy or radiotherapy might be needed too.
And you mentioned therapeutic LPs.
Yeah, in IIH, if the pressure is very high and causing severe symptoms like vision loss, sometimes repeated lumbar punctures can be done to physically remove CSF and lower the pressure temporarily while waiting for medication or weight loss to work.
Is there an urgency to management? How quickly do we need to act?
Extremely urgent. The notes stress this permanent optic nerve damage, and vision loss can happen within days if severe papilloedema isn't treated.
Days. Wow.
Yes. So any suspected papilloedema, especially with symptoms, needs urgent referral. Neurology, ophthalmology, sometimes neurosurgery, depending on the cause. Even if someone seems asymptomatic but you find papilloedema, it's still an urgent referral to find out why the pressure is high.
Okay, urgency is paramount. And monitoring is key, too, presumably.
Constantly. You need to regularly monitor their vision acuity, fields, and the appearance of the optic discs with fundoscopy, often photos or OCT. Follow-up neuroimaging might be needed. It's all about tracking the response to treatment and making sure the vision is protected.
So prognosis. What's the likely outcome for someone with papilledema?
It really depends on the underlying cause and how quickly you treat it. If you catch it early, figure out the cause, and manage it effectively, lower the ICP, treat the tumor, manage the IIH, then the visual prognosis can actually be pretty good.
That's encouraging.
But, and it's a big but, if it's severe or treatment is delayed, that pressure can cause irreversible damage, optic atrophy, permanent vision loss.
Which leads us to complications. The main one seems obvious.
Yeah, the big one, the one we're trying to prevent, is permanent visual loss. From mild field defects right up to complete blindness, that's the major risk of untreated or poorly managed papilledema.
Are there other complications?
Well, the underlying condition causing the papilledema will have its own set of potential complications, separate from the eye issues. So managing that primary cause is vital for overall health, too. Vigilance and proper management are just essential all around.
Okay, so let's try and summarize the key takeaways for someone revising this. Papilledema means swollen optic discs due to raised ICP.
Yep. Critical sign.
It demands urgent investigation to find out why the pressure is high.
Absolutely. Find the cause.
And treatment needs to start quickly to protect vision.
Treat the cause. Lower the pressure. Protect the eyes. Urgently.
Hopefully this deep dive has really helped cement that for your MSRA revision or just general knowledge. Remember those key causes, the mimics, the mnemonics like 2 T's and an M or noodles or hurt, and just the sheer urgency of it all.
Exactly. It's a classic topic because it links neurology and ophthalmology so closely.
It really does, and it makes you think, doesn't it, how a sign in the eye can point to something significant happening deep inside the brain. What other seemingly small signs might be clues to bigger problems. It's a fascinating aspect of medicine.
Definitely food for thought. And look, if you want more structured revision material, practice questions, mock exams, all tailored for the MSRA, do check out passthemsra.com.
And for a brilliant range of free notes, flashcards, and other learning resources covering loads of medical topics, head over to freemsra.com. Definitely worth a look. Thanks for joining us on The Deep Dive.